2 postdocs, and I didn't get the photos in time of the PhD students. So it was some recurrent fever. But when I prepared the talk, I realized there's actually so much I don't know about this, and let me try to talk a little bit about things we know. I hope it's going to be relatively exciting. I hope it's not going to be boring, because that would be the worst. As Marilyn Monroe says, it's much better to be ridiculous than boring. And I just want to start with 3 quotes. Give me the power to produce fever, and I will cure all disease. Who said this? I get a fever that's so hard to bear. Or is fever good or bad? Nobody knows. Well, on the left, we have the famous Hippocrates. Then we have Peggy Lee, which we will speak later a little bit, her favorite song. And then this is my mentor from London, Professor Nigel Klein, who taught me a lot of things. So going back, what is fever? Obviously, there are lots of definitions, and Thomas Sydenham defined it as fever is a nature's engine which she brings into the field to remove her enemy. Which sounds good. Now the problem is, before you speak about fever, you have to define temperature, and it looks like temperature depends very much on age and where you actually are taking it. Is you take it orally, rectally, armpit, ear, wherever. So if we can't really define well temperature, then how are we going to define fever? So they created a group, which was Ron Dagen, a professor from Israel, also took part, and he defined it that fever is basically a body temperature above or equal than 38 degrees. And this is actually not new, because Wunderlich already established this in 1871, where he said everything above 38, that's suspicious, and we should call this fever. If you can hear me, I hope. If there's any problem, let me know, yeah? So my talk, yeah, is a little bit basic, but I think the introduction is important. As you know, it's a hallmark of infection, but also inflammatory diseases. And it has been, yeah, it's more than 2,000 years now that we know that the 4 important things is calor, dolor, rubor, and tumor. And just to remind you that to raise a temperature of 1 degree in a human or in a warm-blooded animal requires actually quite a lot of metabolic input, so more than 10% of increase in the metabolic rate. And then an increase in the core temperature from 1 to 4 degrees has been shown to improve survival. So I just wanted to mention that there was also a time when somebody had fever that the doctors decided to take bloods or to make holes into the brain, and actually probably at that stage it was maybe better not to have money to go to see a medical profession, because the survival rate, this is a little bit provocative, might have been better not to attend a medic. So we all know that we give a lot of antipyretic drugs, but you have to be careful, because it has been clearly shown that it also has an increase in mortality in humans who suffer from influenza, and also has a negative impact in patients who are hospitalized in the intensive care unit. So this is also just a very basic schemata to where you see on the left the trigger, which could be a pathogen-associated molecular pattern such as LPS, which then activates via the macrophages certain cytokines who act on the hypothalamus. And here COX-2 seems to be extremely relevant. And that has an impact on the peripheral tissue, and gives you fever. So, but prostaglandin 2 seems to be a major pyrogenic mediator of fever. And so we go back to the clinical part. It's one of the most common presenting complaints in childhood. It can be acute, or it can be chronic. And infection is probably the most likely cause. Now we're coming to the definition of recurrent or periodic fever. And here it is really, really, as you all know, you're all pediatrician, it is so important to get the story right, to sit down, to listen to the parents, and to go back and listen again. But again, there is no clear definition of recurrent fever. So there have been several publications, just a few of them I want to mention. It's in 1993, it was decided it's a cyclical fever with remission of the disease and a fever-free interval of at least 2 weeks. And then later they said actually it could be 3 or more episodes of unexplained fever in a 6-month period, and it has to be at least 7 days apart. So I think life is a big compromise, and maybe this definition is not so bad. I'm coming up with it's multiple febrile episodes separated by an undefined interval of a normal temperature, because that allows us to include more patients into our definition of periodic fever syndromes. Now the diagnosis is, again, it's taking the history. It's important to do a physical examination. And then it is quite useful actually to ask the parents to write down what is actually happening at home. And then, as I say, you start your investigations, and then sometimes you have to be very fast if it's an underlying oncological problem or an important inflammatory syndrome. But overall, probably it's 50-50. 50% of patients, children with fever, are self-limited illnesses, and then the other 50% are due to this is very simplistic, infectious, inflammatory, or neoplastic problem. Now again, if you go to Wikipedia, that's quite nice. You have the different fever patterns, but the real life is not really like this. You have continuous fever in a child with a pneumonia. You can have remittent fever in children with an endocarditis. I will present a case on this, etc. And then on the right, you have these different fever pattern of could be infectious, rheumatological, autoimmune disease. But overall, there is a very big overlap on this. So you cannot really count on this. And we will see this in the 3 patients I will present. And again, this is also a very simple approach to look in children with fever. I just want to point out that actually there are quite a lot of children, we are admitting, where it turns out they don't really have fever. It's like a bit like a Munchausen syndrome. And then you have the group of fever of not unknown origin, prolonged fever, which could be a pneumonia, an unusual presentation of a common disease, or a child with a Kawasaki disease, which would be an unusual disease, a common presentation. And then you have here the fever of unknown origin, which lasts over 14 days. Again, very simple. You have to be careful, a lot of overlapping. You have to be very cautious. And then when you look at recurrent fever, I just think it is important to be able to diagnose the periodic fever syndrome, the Papa syndrome, because this is really the most frequent one we are dealing with. And then looking at all this, quite like this quote from Winston Churchill where you say you have to go back. Success consists of going from failure to failure without losing your enthusiasm. And that is, I think, what we're all facing when we are working on the wards, and also when we're doing research. And this is just to say that you have your first visit, your second visit, and yes, you do your history. But I think what we sometimes forget, I see it with our juniors, that they don't really ask for a full blood count and a film, because on the film you can see a lot of things. You see activated cells, you see abnormal cells, you see which can help you and direct you. And is there a left shift? Are there very young neutrophils? So could it be sepsis, or could it be leukemia, or could it be an underlying viral infection? Or are they just activated and there's something else going on? And then yes, of course we have to do targeted studies, but we have to prepare the patient. We must not jump into the targeted studies, because that helps also when we send bloods around the world, for instance, to Professor Casanova or to other teams who are able to then really go in deep and do whole exome sequencing. They need to get some information. They need to get some clinical information, which helps them also to look what kind of phenotypic and genotypic studies they would be doing. And that is also, you don't have to look at this, it's just There are many things you can ask for, but they're all in a way incomplete. Yeah, and what is leading is really the clinical picture, because that is really what helps you to look to decide where do I have to look. And that is yeah, this is now my little Peggy Lee. It's the fever. What I say, we see it day by day. And I have to start this again because it was so difficult to load the video. It doesn't work. Yes, it does. We have John Travolta on the other side. It's a Saturday Night Fever. And I think probably the most important thing is the book of Antoine de Saint-Exupéry, Le Petit Prince.
Never know how much I love you.
Where he says that you have... when you fever, think of infection, but there could be other things going on.
I get a fever that's so hard to...
And these things are exactly in the way in immunology, things of autoimmunity, autoinflammation, immunodeficiencies, and lymphoproliferation. And also when we go back 300 years, there was Francesco Totti who described recurrent fever. And when you look at this tree, he was talking about malaria, and he was talking about malaria, and he was talking about malaria. And now, as I said before, the Papa is really the most important thing in autoimmune and autoinflammatory diseases. So we must be able to diagnose or to exclude Papa before we head into all these other autoinflammatory diseases such as hyper-IgD, familiar Mediterranean fever, DIRA, Zika, etc. And again, this tree is very important because it makes tonic. And this is again a quote from Winston Churchill. I quite like it. It's a gin tonic has saved more Englishmen's lives and minds than all the doctors in the empire. Again, it's a little bit provocative, but probably some truth in it. And now I want to go through, if you have enough time, there are 4 children. The first patient is a 3-year-old Spanish girl who presented to us with intermittent fever. She had a 12-month history of tenosynovitis of her left wrist and also some back pain. And interestingly, over her chest wall, there were some skin lesions and she had chronic abscess formation, which needed repeated drainage. When we did initial bloods, they were quite normal except for a raised ESR. And it was quite frustrating because blood and bone cultures all were negative, as were serology. And then a radiography showed these multiple destructive lesions in the left humerus, right femur, and the 10th dorsal vertebrae. And then on the MRI, you could see this huge extradural extension on the level of T10. So obviously, what are we thinking of? Yeah, I would have preferred to be with you and do a little bit interactive. Well, obviously, this is some sort of a multifocal osteomyelitis. The commonest causes at that age, yeah, should be Staph aureus. So he was treated with cloxacillin and clindamycin, and actually followed by 4 weeks of oral cefadroxil, and he had a good clinical response. But did we well? Is it all good? What are we missing? Obviously, I'm presenting this case. Yes, after we stopped the antibiotics, she presented again with fever and has swelling now on her right foot. So it moved to another bone. And this is just a summary of this child who turned out to have Q fever, chronic osteomyelitis for Q fever. And you can see on the bottom, these are the years. This is 1, 2, 3, 4, 5 to 9. This is the clinical, what happened, the tenosynovitis, the abscesses. And then here A and B is where we treated with antibiotics. And here the anti-phase 1 and anti-phase 2 IgG titers. And in the black line is the ESR. So she didn't really respond initially, obviously, to the Staph aureus cover antibiotics. But once she was diagnosed, she was treated for a very long time, for years, on rifampicin and ciprofloxacin. But even then she had breakthroughs, and which you can see here. And it was only when we started her on interferon gamma after excluding a problem in the IL-12 interferon gamma pathway, that she was not only clinically very well controlled, but also her IgG titers dropped. So this is a little bit in line of the talk we were just listening to. So Isaacs and Lindemann in the 50s, they observed in chicken culture that something which was able to stop viral replication. So it interfered. So they called it interferon gamma. And that was, I think at this stage, choosing interferon gamma was a good thing, because this child is doing very, very well. And the second child is also a child, pardon. She is a 4-year-old girl who had a remittent fever. So she never stopped her fever, but she had high spiking temperatures to 40 and respiratory distress. She had a past medical history of a congenital heart disease, which was treated with surgically, and she also had some Contegra valve conduit replacement put in. So what was going on? And in the light of the cardiac insufficiency, the anemia, and the high CRP, yeah, obviously you have to think of bacterial endocarditis. So according to our protocol, she was starting penicillin and gentamicin, but then you can see these gram-negative coccus, which were found to be Aggregatibacter afrophilus, which belong to the Hackett group, and treatment was changed to IV ceftriaxone. So the vegetation at that time was 4 times 5 millimeters. And we have to say that it was decided at that stage not to go in and surgically, because always this is a balance, no, between the risk and benefit. And yes, indeed, she did a good recovery just on the biotics, and she was discharged after 8 weeks, and the vegetation also was much smaller. And again, we were thinking, did we do well? And yes, we didn't do well, because she came back 2 years later, again with a over 2 weeks history of fever up to 40. And at that time, she had a large vegetation of the CVC and 2 additional new vegetations. Yeah, so this was a relapsed bacterial endocarditis. She was started empirically on IV ceftriaxone and gentamicin. However, her blood cultures revealed an endocarditis secondary to Staphylococcus lugdunensis, which is a Coriolis negative Staphylococcus. However, it behaves a little bit like Staph aureus, which is able to induce, is associated with thromboembolism. So it's a nasty bug. Again, was treated with antibiotics and good clinical response. And again, it was decided not to intervene, and she only went home for a week and came back. And at that time, she had although the blood cultures were negative, you could see on the echocardiography that the vegetations were huge. And she also had, on the chest CT, had some scan showed some evidence of pulmonary embolism. So now, really, the cardiothoracic surgeons went in and cleaned out the material and put new material in. And since then, actually, she was discharged and remained in very good clinical state. So, what do we learn from this case? Yes, pediatric infective endocarditis can be caused by uncommon microorganisms, and actually, Staphylococcus lugdunensis is associated with high fatality rates in adults over 20% and in children above 10%. So you must consider these microorganisms as relevant, and you always need to rule out a cardiac involvement. The problem is, how long do we treat? There are lots of protocols, and when should we really go in and intervene? What is complicated? So that remains to be discussed. When should we really push more the surgeons to intervene? So this is a case where you really need to expect the unexpected. Now the third patient, It's a patient we shared actually with Jean-Laurent Casanova also. He's a 4-year-old male born, non-consensuous parents who had a 3-month history of generalized lymphadenopathy, rash, fever, and night sweats. Unremarkable family history, but interestingly, he did actually suffer from from Salmonella gastroenteritis invasive, which required 1 week of IV antibiotics. So he already had, at the age of 1 year, some problem with intracellular bacteria. And his initial bloods were really striking with a neutrophilia of 45,000 and a high CRP of over 300. Now, in this case, also, we repeated blood culture and they all turned out to be negative. Basic immunology studies at this moment revealed overall normal immunoglobulins, while IgG on the high side, lymphocyte subsets and the PHA to T cell activation were normal, and CGD was ruled out doing a respiratory burst test, which was also normal. Now, he continued to have high fevers, and we did a bone marrow, we did a lymph node biopsy, and we also went into the lung because he had quite respiratory problems, and we didn't grow anything. And we got worried because there was no signs of malignancy, but there was also no clear signs of HLH. We couldn't find a bacteria. So we didn't know what we were treating, or we had to do something. So he was empirically treated with Septrin and imipenem, as well as an antifungal. And quite strikingly, within a few days, his fever disappeared and he was clinically improved. And he was discharged, obviously, with initially weekly follow-up. But we were very worried because we didn't know what was happening. And then he came back and he had fever and he had general lymphadenopathy and marked hepatosplenomegalia. And you can see this really disseminated rash he had and this huge lymph node here, which was absolutely striking. And his neutrophils went up to 120,000. So that is something I have never seen before. His ESR was very high, CRP 100. His IgG, which at this age should probably be at 1,000 to 1.2, went up to 4.7 gram. And soluble CD25 as a marker of activation, macrophage activation, was also 100 times elevated. So this is when we went back and did the biopsy, and we finally got something we were suspicious of. We got a mycobacterium, and he was treated with triple therapy, and he got well. He responded very well. But this is clear now. This child, something is going on, and we need to look what could happen. And this is what you all know when you have an atypical pathogen in the context of this, you must do functional studies and look into the IL-12 interferon gamma pathway. And that's what we did. We did this also with Carlos Rodriguez in Las Canarias in Spain. And basically we measured high levels of interferon gamma. And it was also we could show that this patient was able to produce interferon gamma, but he wasn't able to use IL-12. So, and I will explain this a little bit later. So you can see here the patient, and here's the control, and here you stimulate with LPS, and then you give an increasing dose of interferon gamma, and you can see that the patient is not responding. He cannot make IL-12. And also, when we looked at the expression of the interferon gamma receptor 1, you can see here, this is a healthy control. It's a nice shift to the right, and this is a patient who does not express interferon gamma. So was this a complete interferon gamma receptor 1 deficiency? Yes, it was then sequenced finally in our hospital, and so this is a very rare but potentially fatal disease. And as I said before, he did respond very well on these antibiotics alone. So just to show you what happened is that this is the macrophage who was infected, in this case with an atypical mycobacteria, and he tells the T cell, the NK cell, please kill me. So a lot of interferon gamma production, but very frustrated interferon gamma, which cannot dock on the receptor, and therefore you have this interferon gamma floating around in the blood and infiltrating and activating the immune system on all levels, which results into this, which has impact on the skin, on the liver, on the lung, etc. So here, this is a patient where actually the interferon doesn't seem to be such a good thing. It's not helpful. So now we have this problem, and what do we have to do? We have to cure him. And the only cure at this stage still is a hematopoietic stem cell transplantation. So we did a myeloablative conditioning, and he actually had a nice chimerism above 90%. His brother was a matched sibling donor, which was very fortunate because initially his brother had also a congenital heart disease. So he was not, per se, he could not be the donor. So first, this cardiothoracic had to treat the son as a brother so that he can be then a healthy donor. So it was quite a challenge. And then we measured interferon gamma levels, obviously pre-transplant. That was very important to bring that down. Then we discussed this with the group in Paris and with Professor Casanova. And we could bring the interferon gamma levels down pre-transplant and also post-transplant. And after 1, 2, 3, 4, and then later, they were less than 10 picograms, so negligible. He also, I show you this now, is now able, he did a full immune reconstitution. This patient is now able to produce IL-12 when once stimulated. And also you can see here, interferon gamma R1 receptor 1 expression is normal in monocytes, granulocytes, and B cells compared to a healthy control. So it was really a very nice, happy end story. Very many people involved in the management, initial management of this, and with a fantastic outcome. And he's still, well, he's doing very good. I just saw him last month. He's nearly 7 months out of transplant now. And finally, I'm going to just present you one autoinflammatory patient, which is a four-year-old boy who had a very early onset on problems. So already with the age of 1.5 months, he showed recurrent admissions for fever of unknown origin, diarrhea, vomiting, and then going in the direction of failure to thrive. This is a patient of my colleagues and my group of Marisol Camacho and Maribel Garcia. They are our rheumatology team. So when they did the endoscopy at the age of 6 months, it was initially normal. And then in the colonoscopy, they saw a bit of hyperplasia, but very unspecific changes. You can see here the hyperplasia of the colon, yes. So then he was diagnosed with Crohn's-like. And that is also something you have to be very careful. A child less than 1 year old, there's something else going on. This is not just Crohn. You have to find, you have to think, could this be an underlying genetic defect? Anyhow, so he was treated on steroids, which obviously everybody gets a little bit better on steroids for a while, but then he came back and had again fever and very raised inflammatory markers, and always, I mean, we could never really isolate a bacteria. So when he was 4, so this is more than 3 years later, he still continued to have recurrent fever and his septic episodes without identifying a microorganism. It was really thought what to do. And if you don't know what to do, you have to go back and you have to repeat things and you have to expand and you have to speak to people, to friends, to colleagues, and just do brainstorming. And so this time they could show that there were some lymphocytic hyperplasia in the ileum and also some lymphocytic infiltrations. I just wanted to show you let me see, on the right, you can see here, this is the weight, which is always below the 3rd centile, and this is the height, which is around the 3rd 10th centile, so on the lower side. He was thriving, but but clearly on the low side. So then our gastroenterologist said it doesn't make sense what we see when we do the biopsy. It does not correlate with the clinical picture. And this is where he was referred to our rheumatologist and to us, because he also, when we reviewed the history, it was clear that he had actually a lot of problems with adenopathies. He had problems with these episodes post-vaccination, so it was like such a trigger. He didn't have exanthemas, he didn't have involvement of the bones at this age, but he's only 4 years old. So we say, well, this is a recurrent fever syndrome, whatever it is, and we have to study this. And we put him into our panel for next generation sequencing. So this is years ago, which was a panel of 125 genes. Now we have expanded, now we are on 300 genes. But again, this is not complete, but he got two mutations for the MV key gene. And so he was diagnosed genetically, and actually it does fit with the hyper-IgD syndrome. If you look at this, the onset is less than 1 year. The trigger, he had abdominal problems. But again, this is very, very, very simple. And you can see the autoinflammatory syndromes, they have a lot of overlapping. And I will mention this in a minute. I just want to finish with the case. So as I said, he was found to be compound heterozygous in the MVK gene, which is autosomal recessive. And initially was started on steroids and colchicine, then changed to anakinra, anti-interleukin 1, then anti-TNF. And now over 2 years now, even longer, he is on monthly canakinumab and is very well controlled. And you can see here also how he's catching up with his weight and his height. Okay. This is what I wanted to say about the anti-inflammatory, autoinflammatory diseases. Sorry, this is Marco Gattorni is a professor in Italy. I know him very well. He's leading the Eurofever registry. And basically, there's a lack of accuracy of diagnostic criteria in the autoinflammatory. So what he did is, and I think it's very clever, he did a Delphi questionnaire involving over 150 physicians. And he took 360 patients out of this Eurofever registry, and then he looked at them and asked the doctors to decide in which pot you want to put this, if he has this kind of clinical features. So you have on the FAPA, the CAPS, the FMF, etc. And what you can see is there was a quite good correlation on sensitivity and specificity. But what does the impact of this is that we are able to to put patients, I wouldn't say in a box, but at least they can be included in studies and they can have access to treatment. But it is also important to say that these things are not a diagnostic criteria. You need to do your genetic studies. And I just want to finish with a few patients of mine, of us, and these are all patients who had fever, but there was much more going on. So on the left, you have a patient with CGD and has a liver abscess who got better, only got better when we added steroids to his antibiotic cover. This is a father who has autoimmune lymphoproliferative syndrome, who's well controlled on sirolimus. This is STAT1 gain of function. These children have infection, inflammation, autoimmune disease, and susceptibility to candida infection, who is doing very, very well now on a JAK1 inhibitor. And I have a child with a STAT3 gain of function who is on mycophenolate, is doing well. We have a few patients with P13K data gain of function, APDS-DOS, who is too young to be on a specific treatment, but is doing well on sirolimus. And then we have a patient with LRBA who's, oops, I don't know if you can see this. You can see this really horrible lung who's on abatacept treatment. I presented this case with hyper-IgD syndrome to you, and we just diagnosed with the adults another patient with LRDA. So is fever good or is it bad? Well, probably for an infection, it's good to have fever because it does activate your immune system. It does help to clear infections. And autoinflammatory disease is probably more detrimental. And just a little summary, I think, just keep in mind when you have a patient with fever that is not everything is infectious. You need to listen. You need to think when the parents speak to you. And then really you need to have a good communication, and you need to get your priorities right, because that's how you can really optimize the diagnosis and the management of these children. And this is a course I'm doing every year in Seville. This year it couldn't happen because of the COVID. Hopefully next year some of you can come. It will be advertised in ACID and ASPID. And this is just to see how this is ongoing, growing, and how we work together. We have daily and then monthly meetings with the adults. And also we are working obviously on a national and international level, and having some very nice collaborations, which I'm very happy about. Thank you very much.
So thank you, Dr. Olaf, for your great presentation, amazing slides, great quotes, and also amazing music. And also I hope that we're able to see you next year in your lecture, hopefully. And maybe you can join us here after COVID. You can come to Iran. We will be more than glad to have you here and to welcome you. We can't wait to meet you in person. So there are a few questions in the chat section, if you don't mind to answer. So I'm seeing a question about the first case that you presented. They're offering and they're sharing another differential diagnosis of chronic recurrent multifocal osteomyelitis, or CRMO. Do you have any explanation about that, or do you want to add anything to this?
I think I don't understand the question. Yes, it was a chronic osteomyelitis, but secondary, it was not aseptic. It was a septic arthritis. It was we found this bacteria, Coxiella, and we treated it. And the treatment is very, very frustrating. There are some series in Australia. We spoke to, I think her name was Dr. Nurse, and probably we were the first to check whether an immunomodulatory therapy would be beneficial in these patients, because this is an intracellular pathogen, which it seems we were not able to eradicate just with antibiotic treatment. So it's like a turbo, no? You give this interferon in a low dose, and it did help to clear. Was this more or less what the person wanted to know? I can only see you now. I don't know. Also,
you can click, there's a chat button down there. You can see the chat. If you click on it, the chat will open for you, the chat window. Can you see that?
Okay, go on.
Find it? Okay, so there's another question. Actually, these are for the infectious causes of a fever they're asking. So there's a question about post-cardiac surgery fever, especially the immediate ones after the surgery. So yes. What would you talk about? Would you explain about that? Do you suggest laboratory examinations for that, or do we wait?
No, that's a really good question, and we discuss it all the time. It's not just to ask, not just to do to take blood tests. It's also imaging. You know, when we have fever post-operator, post-intervention, which is very common to have fever, then we think, should we do an MRI? Should we do some other imaging? And then probably it doesn't have much impact, because it is normal. It is normal post-intervention that there is some inflammation going on for a while. But I would say if it's recurrent and if it is, the other thing is that we had problems with abscess formations, no, in open cardiac surgery. So there, I suppose you have to be aggressive, and yes, you do have to do your imaging. But just to do your bloods is not helpful, I think, in the immediate period post-operative. I agree.
Okay, so thanks for that. And the last question I'm seeing in the chat section is actually a question about COVID-19 and the process of fever formation in these patients. So do you have any explanation or any ideas that you want to share about this as well?
Yeah, this is what we all see now, more or less. In the first wave in March and April in southern Spain, we were well lucky. Yeah, we didn't have so much problem with this kind of systemic onset, no, which is like Kawasaki-like, or well, new words. They're new. It's a new diagnosis, but I don't think it is a new diagnosis. We have always seen in springtime these inflammatory processes in children who were very, very sick and went to the intensive care, which was like an HLH-like or Kawasaki-like period. But now we're seeing this in the second phase. We do see this again. So it might be, I don't know the answer, that's for sure. I don't think anybody knows clearly the answer of this, but it appears that some of these patients come back to us after they had an infection with COVID, and somehow the immune system has been provoked by this virus in a way that when it then sees another pathogen, it reacts, and it totally overreacts as it wouldn't do normally, I think. So we don't see prolonged, but we do see, yes, we see recurrent fever syndromes, and some of which are associated with a previous history of COVID. Maybe like this, I would say.
Okay, so thank you so much. Thank you again for sharing your expertise, your experience with us, also joining us and giving us your precious time. It was great to meet you again. And hopefully we will meet you in person in Iran or even in Seville in your next lecture, hopefully.
Very good.
Okay. Okay, so thank you. Have a great day. So
you too.
I'm going to go to our next lecturer, Dr. Ghodousi. So I'm not seeing his name in the participants. So we had a backup video from him. So
Dr. Ghodousi just texted us, and he asked for his, he just says his apologies to our audiences and says that he's somehow involved in another section that was and he couldn't just be with us for tonight. So let's go for the pre-recorded session.
Yeah, that's so sad. Okay, so we're going to go to with the recorded ones. So.
Good afternoon, everyone. It's a pleasure to be among you in this 32nd International Pediatric Congress. My name is Arash Ghodousi, and I'm an assistant professor at San Raffaele Scientific Institute and Università Vita Salute in Milan, Italy. In this presentation, I'm going to talk about the whole genome sequencing for infectious disease diagnosis with a focus on diagnosis, genotyping, prediction of resistance, and outbreak investigation of Mycobacterium tuberculosis and non-tuberculosis mycobacteria. So my talk will be in 5 parts. We will review the terms and definitions of next-generation sequencing and whole genome sequencing. We will review the utility of whole genome sequencing for diagnosis and genotyping of Mycobacterium tuberculosis, for prediction of resistance, and for outbreak investigations. We will also review the whole genome sequencing in NTM research for identification and outbreak investigations. As you may know, hospitals worldwide are facing an increasing incidence of hard-to-treat infections. Limiting infections and providing patients with optimal drug regimens require timely strain identification as well as virulence and drug-resistant profiling. Additionally, prophylactic interventions based on the identification of environmental source of recurrent infections and reconstruction of transmission chains could help to reduce the incidence of nosocomial infections. According to the latest WHO Global Tuberculosis Report, around 10 million people developed TB in 2019, and 1.4 million died, and TB still is one of the top 10 causes of death worldwide and the leading cause of death from a single infectious agent, even ranking above HIV/AIDS. Due to the current COVID-19 pandemic, WHO estimates that the global number of TB deaths could be increased in 2020 if health services are disrupted to the extent that the number of the people with TB who are detected and treated falls by 25 to 50% over a period of 3 months. In 2014, the WHO announced its End TB strategy. A target was set to reduce global tuberculosis incidence by 90% on 2050 rates by 2035, corresponding to fewer than 10 new cases per 100,000 population per year. Intensified research and innovation was pronounced one of the 3 pillars upon which to build success. There was a call for new tools to be ready by 2025, including a vaccine, better prophylaxis and treatment regimens, and a point-of-care test. As a new tool, whole genome sequencing is one of the most exciting and disruptive technologies to take to the stage for decades, with advances in nanotechnology now promising to deliver affordable and accessible sequencing platforms that are simple to use near the patient. These developments are perhaps more important to the management of tuberculosis than any other infectious disease due to the diagnostic delays stemming from the slow growth rate of Mycobacterium tuberculosis complex. Now let's turn to the first part of my talk, which is about the next-generation sequencing technology. As you know, Sanger DNA sequencing, developed in the 1970s, enabled the first gene and genome sequences, but remained limited in the application due to the complexity and high sequencing cost when applied to the extended genomic region. But the sequencing output increased tremendously with the advent of pyrosequencing and then next-generation sequencing methods in mid of 2000, when costs were reduced. By the end of the sequencing reactions, the next-generation sequencing platforms generates the sequences of unique DNA fragments known as sequence reads, which can be either be short or long depending on the type of the platform that we used. But a single NGS run can produce billions of sequence reads. But what is the whole genome sequencing? The whole genome sequencing is a process to determine the near complete genomic sequence of an organism. Whole genome sequencing is one of the things you can do with NGS technology. The workflow of the next generation sequencing is similar for all the technologies: extraction of genomic DNA, preparation of DNA libraries through DNA fragmentation that can be enzymatic or mechanical, barcoding and PCR amplification, clustering, and finally automated single or pair-end sequences that we can use for whole genome sequencing, for RNA sequencing, or targeted sequencing. After the sequencing, the next step, that is the most challenging step, is bioinformatic analysis. So in this step, we will do the genome assembly or gene expression profiling and or phylogenetic classification to reach to the final results, which help us to the diagnosis of the bacterial infections, for the outbreak control, for the resistance predictions, and biomarker discovery. Now I'd like to change direction and talk about the utility of NGS technologies such as whole genome sequencing in diagnosis and surveillance of MTB and non-tuberculosis mycobacteria. So the question is that how NGS can help in diagnosis and surveillance of MTB and NTMs. These technologies can help us in taxonomy and species and subspecies identification, in drug resistance prediction, and in cluster analysis and investigations of suspected outbreak. Based on this technical guidance that was published in 2018 by WHO, NGS has great potential as a method for rapidly diagnosing drug-resistant tuberculosis or DRTB in diverse clinical reference laboratory settings worldwide. The NGS approach overcomes many of the significant challenges associated with conventional phenotypic testing, as well as the limitation of other less comprehensive molecular tests by providing rapid, detailed sequence information for multiple gene regions or whole genome of interest. However, the uptake of these technologies for DRTB diagnosis has been hindered by concerns regarding to the cost, integration into existing laboratory workflows, technical training, and a skill requirement for utilization of the technology, and the need for expert guidance regarding the management and the clinical interpretation of the sequencing data. So in this slide, you can see the current implementation of the whole genome sequencing in tuberculosis research. In the TB diagnosis, the gold standard is still culture-based methods, but this method takes too long to be clinically useful. For the TB diagnosis, highly sensitive, rapid and accessible diagnostic are needed. So there are some rapid molecular assays endorsed by the WHO for diagnosis of tuberculosis, which one of the most used one is the GeneXpert MTB RIF assay. Expert
So sorry for the inconvenience. I'm seeing a voice problem with the pre-recorded session of Dr. Ghodousi. We're trying to fix it, so sorry and thanks for your patience. We'll be back in a few minutes.
based point of care assay is designed to identify rifampicin resistance, but in a limited area or hotspot region of the RPOB gene, which is 81 base pair region of RPOB, codons 426 to 452. So here in this slide, I will show you one of the limitations of the expert MTB RIF assay and the power of whole genome sequencing to solve this limitation. As you remember from the previous slide, expert MTB RIF assay is designed to identify rifampicin resistant mutation in a limited region of the RPOB, which is an 81 base pair region from codon 426 to codon 452. As you can see in this minimum spanning tree, in a survey study in Swaziland, which is a country with high prevalence of tuberculosis, we have found a very big cluster of MDR tuberculosis patients. Looking at the MTB RIF assay, the result was MTBC positive, but susceptible to rifampicin. But doing the whole genome sequencing, we have found that these patients, in fact, are MDR patients because having a mutation in RPOB, which is outside the region that MTB RIF assay can detect it. So this mutation is conferring resistance to rifampicin. This mutation, which was previously reported with low frequency in clinical isolates from Hong Kong and Australia, is not detected by expert MTB RIF assay. So in such case, whole genome sequencing is the only method can help us in order to not miss any mutation in drug-resistant related genes and to prevent the transmission of Mycobacterium tuberculosis. Or in this study that we have published in the New England Journal of Medicine in 2018, we obtained whole genome sequencing and associated phenotypes of resistance or susceptibility to the first-line anti-tuberculosis drugs, including isoniazid, rifampicin, ethambutol, and pyrazinamides for isolate from 16 countries across 6 continents. For each isolate, mutation associated with drug resistance and drug susceptibility were identified across 9 genes, and individual phenotypes were predicted unless mutation of unknown associated were also present. As you can see, the resistance to the first-line anti-tuberculosis drugs was correctly predicted with a very high sensitivity. The conclusion of this study is that whole genome sequencing can predict profiles of susceptibility to first-line anti-TB drugs with a degree of accuracy sufficient for clinical use. Or in this study, we have used the whole genome sequencing and corresponding MIC testing to correlate the level of resistance to isoniazid in a set of phylogenetically diverse strains. As you can see, strains with different mutations in CATG or INH or combination of mutations are related with the diverse MIC values. The level of resistance is not detectable by any molecular methods. So the whole genome sequencing can be a method to predict the level of resistance to antibiotics and can help the clinicians to choose proper therapeutic regimens. Or in another study, the clinical use of whole genome sequencing, we have done a study in bedaquiline surveillance in Pakistan. For those who are not familiar with bedaquiline, this drug is a novel antimycobacterial agent that has been shown to have significant in vitro and in vivo activity against Mycobacterium tuberculosis. And it is associated with improved clinical outcome. So in 2019, the WHO classified bedaquiline as a group A to be used for the first-line treatment of drug-resistant TB. In this study, we report on the first 6 cases of acquired resistance to bedaquiline in Pakistan. 70 sequential isolate from 30 drug-resistant tuberculosis patients on bedaquiline-containing regimens were tested for bedaquiline resistance by MIC testing and using whole genome sequencing to detect the mutations in relevant genes. We documented cases failing therapy that develop a specific mutation in an efflux pump coding genes called RV0678 and had increased MIC associated with cross-resistance to clofazimine during treatment. This study underlines the relevance of surveillance programs following the introduction of new anti-TB drugs. Moreover, it is not possible to detect these new mutations, with the rapid molecular drug susceptibility testing that currently available, including the GeneXpert or line probe assay platform. But it is possible using whole genome sequencing to detect these kind of mutations. But the major challenges of mutation and their relationship with resistance is that not all mutations confer resistance. There are some mutations that they are phylogenetically related or polymorphism that should be excluded. One of the good examples of these kind of mutations is in the codon 463 of CAT-G genes, or S95T in GIR-A, that they are phylogenetically related and should be excluded while screening for the mutations. Moreover, the role of synonymous mutations should be considered. For example, in FABG1, there is a mutation leucine 203 leucine that is related with the isoniazid resistance. So these are the major challenges that we have to consider. Now let's talk about the utility of whole genome sequencing in TB epidemiology. Currently, Mycobacterium interspaced repetitive unit variable number of tandem repeats, or miru-VNTR typing, is a commonly used molecular genotyping for MTB. But is VNTR genotyping good enough? This method interrogates only a small fraction of the genome, only surrogate markers. So the problem is the lack of discriminatory power, especially in highly conserved genotypes like Beijing strains. And this method can rule out transmission, but cannot rule in the transmission. So these are the limitations of this technique. One of the first study of use of whole genome sequencing in TB epidemiology was published in New England Journal of Medicine in 2011. An outbreak of tuberculosis occurred over a 3-year period in a medium-sized community in British Columbia, Canada. The result of miru-VNTR genotyping suggested the outbreak was colonal, but traditional contact tracing did not identify a source. So the whole genome sequencing and social network analysis showed that in an effort to describe the outbreak dynamic at a higher resolution. Whole genome sequencing result showed 2 genetically distinct lineages of Mycobacterium tuberculosis with identical miru-VNTR genotypes, suggesting 2 concomitant outbreaks. So the conclusion of this study was that the genotyping and contact tracing using the conventional methods like miru-VNTR did not capture the true dynamics of the outbreak. So during the recent years, whole genome sequencing has been used successfully to investigate Mycobacterium tuberculosis isolates associated with tuberculosis outbreaks and to elucidate mutations conferring drug resistance. Enhanced contact tracing and investigation and improved diagnosis and treatment of latent TB infections are an important strategy for TB control and elimination. So here is the major conclusions of those studies of implementation of whole genome sequencing in TB epidemiology. Whole genome sequencing has a higher discriminatory power and most likely is able to subdivide clusters defined by classical RFLP VNTR genotyping. proposed cutoff value of less than 6 SNP or single nucleotide polymorphism between isolates predict links established by conventional epidemiology for recent transmission events. This cutoff value could be used for identification of isolates involved in the direct human-to-human TB transmission. Moreover, whole genome sequencing allowed distinguishing between isolates sharing identical genotyping patterns, potentially separating transmission chain with RFLP VNTR clusters. It identified false clustering, ruling out false transmission event. But what is important is that this 6 SNP cutoff is not as absolute cutoff, especially in drug-resistant strains. So let's continue this session on whole genome sequencing based non-tuberculosis mycobacteria or NTM genomic characterization. Gene sequencing is the reference method for the identification of the NTM species. Single target sequencing cannot be used to accurately differentiate a species. Routine laboratories use line probe assay technology for species identification, but a higher level of discrimination on the subspecies level, gene sequencing of several targets using key genes such as HSP65 and RPOB or the 16S23S internal transmission spacer is needed. But whole genome sequencing provides NTM species identification with higher accuracy. One of the examples of this high resolution or high discriminatory power of whole genome sequencing is on finding the subspecies of Mycobacterium abscessus in 2013 using the whole genome sequencing. So now we know that Mycobacterium abscessus contains 3 subspecies of abscessus, bulletti, and massiliense. So the whole genome sequencing helped us to discover these subspecies in the Mycobacterium abscessus species. But how NGS can help us in diagnosis and surveillance of NTMs, cluster analysis and investigations of suspected outbreak? NTM pulmonary disease is thought to be caused not by human-to-human transmissions, but by independent environmental acquisition. However, NGS-based studies have hypothesized transcontinental spread of Mycobacterium abscessus among patients with cystic fibrosis. So let's move to the last part of my presentation that I talk about the utility of whole genome sequencing for genomic analysis of cardiac surgery-associated Mycobacterium chimera infections in Italy. Mycobacterium chimera is a slow-growing non-tuberculosis mycobacterium in the Mycobacterium avium complex. However, Mycobacterium chimera has a virulence greater than other Mycobacterium avium complex. In 2015, the infection control team at University Hospital Zurich reported that multiple patients had infections due to Mycobacterium chimera following open heart surgery. First case dates back to the surgery performed in 2012. Reported latency of infection was 18 to 43 months after surgery. Mycobacterium chimera was then cultured from the blood, cardiac tissues, and other surgical specimens for all cases. Mycobacterium chimera was also cultured from the heater cooler unit used for cardiac surgery bypass during the surgery and from the air samples in the surgical suits. Thousands of cardiothoracic surgical procedures annually happen in the world, raising concern that the cases detected so far are only the beginning of the larger problem. Because Mycobacterium chimera infections are extremely difficult to treat, and patients with such infections have a mortality rate of approximately 50%. During the heater cooler unit operation, the organism has been shown to aerosolize via the exhaust of the contaminated device, resulting in airborne inoculation of the surgical site and the infection after the surgery. Although there is no direct contact with the patient or with the patient blood and the HCU, however, from the air of the surgical rooms, they have isolated Mycobacterium. So the two immediate priorities were raising awareness to improve case finding, but there was challenges with these. Symptoms onset is delayed from the time of surgery, if you remember from the previous slides. Also, there is no screening test to assess asymptomatic patients for exposure or infections. Moreover, mitigating the exposure risk by advising hospitals regarding disinfection and use of their heater cooler units. But the challenges is that the LivaNova is a brand of HCU producing factory that has the largest share of the HCU market in the world, more than 60% to 80% worldwide. And the problem is that the HCUs of the LivaNova is shown that they got infected, they got contaminated, not infected, they got contaminated in the factory and they distributed to the hospitals to the world. So the problem is that it is impossible to recall all HCUs from hospitals without disrupting the availability of lifestyle cardiac surgery. Moreover, Mycobacterium chimera is virtually impossible to eradicate from the HCUs once it has colonized the water circuits. That we will discuss this problem in the next slides. So the situation is in Italy is that more than 40 patients undergo cardiac surgery every year in Italy. A national survey endorsed by the Italian Society of Cardiac Surgery in 2017 found only 3 patients affected by Mycobacterium chimera infection. By 2019, the total number of published cases of Mycobacterium chimera infections after cardiac surgery in Italy increased to 12 cases. There are also reports from more than 20 countries in 4 continents, and more than 150 confirmed cases worldwide were reported. So in our study, we have received 122 Mycobacterium chimera strains from patients with open heart surgery and without open heart surgery, and also from the heater cooler units, and submitted to whole genome sequencing and subsequent SNP analysis for strain genotyping and cluster analysis. And as you can see here, the red one, the Mycobacterium chimera from the cardiac surgery patients, and the blue one are from the heater cooler units. As you can see very clearly, the strains from the patients with open heart surgery were very similar to the isolates from the heater cooler units with less than 5 SNP difference. So here it confirms the transmission of this bacteria from the heater cooler units to the patients who did the cardiac surgery. Moreover, we have used the whole genome sequencing for strain classification for genotyping, like MTB, that we says that this is lineage 1, lineage 2, this is Beijing, this is Euro-American. Also for Mycobacterium chimera, we have created an algorithm for the lineage and sublineage identification. Moreover, in these 125 isolate,
we have found also a unique lineage of Mycobacterium chimera that was not reported previously. So here you can see that using the whole genome sequencing, how many works or from how many aspects we can study the isolates. Here in this slide, I will show you an interesting utility of whole genome sequencing for detecting the bacteria and to confirm that this bacteria is identical to the one that we isolate previously. Here, if you see, this is a schematic view of a heater cooler units having two tanks, one of them for cold water for the heart bypass, and the other one is warm water for the regulation of the body temperature during the heart surgery. So, receiving the samples from these two tanks, in March 2019, we have isolated Mycobacterium chimera from the same subgroup. And from the same subgroup that is believed to get contaminated from the factory in Germany. After the disinfection procedure, the standard disinfection procedure recommended by the ECDC, we have received the subsequent samples, and with the culture-based studies, we have isolated the Mycobacterium chimera. But using the whole genome sequencing, it confirms that these are the same as the previous isolates, with having less than 5 SNP difference. So in this slide, we can see that the disinfection process were failed. As I told you previously, it's very difficult to eradicate Mycobacterium chimera when colonized the HCU. Or from another heater cooler unit, from the pre-disinfection step, we have received the sample and we have detected from one of the tanks 3 different Mycobacterium chimera lineages or groups. So this is due to the high resolution of whole genome sequencing that we can detect the same species but from different lineages or from different groups. And from the warm tank again, we have detected almost the same subgroups, as you can see. The disinfection process was performed and we received the samples, and as you can see, we detected the same Mycobacterium chimera as before the disinfection was done. So here again the disinfection was failed. So it confirms the high resolution of whole genome sequencing to detect more than one Mycobacterium chimera strain. So in conclusion, next generation sequencing based approaches are the tools for NTM's new species, subspecies identification. Whole genome sequencing allows for sequences to be quickly compared across the globe to facilitate the investigation of transmissions pathway and potential point sources. Whole genome sequencing predicts drug susceptibility with great accuracy, but more work is needed to increase the proportion of the prediction made. And by this slide, I would like to thank you for your attentions.
Okay, so thanks to absent Dr. Ghodousi for sharing his slides and sharing his lecture for us. A special thank you to all of our lecturers for joining us. A special thanks to all of our participants for joining us today. And thanks to our sponsor, Pediatrics Incorporated, for sponsoring this session. Thank you all for joining us. Don't forget, we have another sessions tomorrow, gastrointestinal sessions, allergy and immunology, ICU session, and also nephrology. You can find the information about them in our website and also on our social media. So there was a question in the chat section about the attendance certification. If you want to receive attendance certification, please, you have to register on our website and give us your email. So and you have to reserve a seat on your desired panels. And after this webinar and this Congress is over, we will email you the certificates. And also for our Iranian audiences, if you want to receive CME credit, you have to participate in the CME quiz to be qualified for the credits and to get them. So as you can see here in this picture, the CME registration site, that for our Iranian audience, you can see this CME quiz site that you have to take the quiz to get the CME credits. You can see our website actually address for panel registrations and attendance certifications. Also, you can see our Telegram channel and also our Instagram. Thank you again for joining us, and don't forget to follow our social media. Don't forget to follow us and join us tomorrow for our great panels again tomorrow. And thanks again for being with us tonight. Have a great night and goodbye.
Goodbye.
Bye, Dr. Olaf. Goodbye.
Take care. Leaving.